do have two videos that we're going to share with you this morning. Our legislative champions, I know you saw the Ben Cardin video. He was one of the senators that we awarded with our NABH Legislative Champions Award this year. We did a similar award for Senator Rob Portman out of Ohio, and also for Congressman Greg Walden out of Oregon, I believe. So if we can cue those videos, we'll get the program started. Thanks.
Hi, I'm U.S. Senator Rob Portman. I really wish I could be with you all today in person, but I'm with you in spirit, and I'm very honored to receive the National Association of Behavioral Health Care's Legislative Champion Award for our work to combat the opioid epidemic, and specifically for lifting the IMD exclusion. As you know, I fought for several years to lift this outdated and unnecessary barrier to treatment. It really was an arbitrary barrier. I'm really pleased to report that we were successful in doing so as part of the opioids legislation signed into law by the President late last year. We know that access to treatment is one of the biggest obstacles we face in helping more Americans who are suffering from addiction. And lifting this cap is great news and an important victory in our efforts to expand access to treatment for those who truly need it. We achieved other important victories in this new opioids law, by the way, including my bipartisan STOP Act legislation to help stop the flow of fentanyl from being shipped into the U.S., mostly through China and mostly through the mail system. And also the CRIB Act legislation I co-authored, which helps newborns born dependent on drugs to recover while providing support to their families. I want to thank you all for everything you do on the front lines in our communities to help turn the tide of addiction. We're starting to make some progress, but so much more work to do. I'll continue to do my part to be sure Washington is a better partner with state, local government, and nonprofits, and I look forward to continuing our work together. Thanks again, and Godspeed in your important work.
Greetings, and thank you for honoring me with the National Association of Behavioral Health Care Champions Award. I want to especially recognize Sean Coughlin for the leadership of the National Association of Behavioral Health. And I thank all of you here today, and I wish I could be with you in person for this conference, but I am proud to have worked alongside your organization to strengthen mental health care and substance abuse treatment. You know, in the last Congress, we passed into law my legislation to combat the opioid crisis, the Support for Patients and Communities Act. We all know someone who has been hurt by the opioid crisis, a friend, a neighbor, or a loved one. This scourge has reached my district in Oregon, and no community in our country has gone untouched by this killer. This crisis does not discriminate, not by race, socioeconomic status, gender, age, or political party. That's why we had enormous bipartisan support to tackle this crisis that takes the lives of more people than are killed in traffic accidents. Combating this crisis requires an all-hands-on-deck approach. That's why the Support for Patients and Community Act gives more tools to those on the front lines of this fight in our communities. This law will help efforts to advance treatment and recovery initiatives, improve prevention, protect our communities, and bolster our efforts to fight deadly illicit drugs such as fentanyl. This represents the largest congressional effort to address a single drug crisis in our nation's history. Seldom are there times when you're legislating that you can say that what you're doing will actually save lives. This is one of those times. While there were good provisions that were left out of the final bill, such as the legislation on 42 CFR Part 2, which would have given providers access to needed patient information when treating addiction, the Support for Patients and Communities Act was a big step forward and in a better direction. But just as this was not our first effort in this fight, you have my word that it will not be our last either. And I will continue to work to get into law the important provisions that frankly didn't make it into H.R. 6. And I'm hopeful that we can come together again in a bipartisan manner to combat the opioid and drug crisis and treat addiction. I'm hopeful because there's been a long history of bipartisanship on these issues, especially at the Energy and Commerce Committee. We saw that the landmark 21st Century Cures Act, which Fred Upton and Diana DeGette worked so hard on, they came together and passed through our committee and into law. This sweeping law included $1 billion over 2 years in funding to address the opioid crisis, as well as the Helping Families and Mental Health Crisis Act. The Helping Families and Mental Health Crisis Act was the first significant overhaul of the nation's mental health system since the Kennedy administration. This law streamlined and reformed the 112 federal programs that address mental health to ensure they effectively coordinate and remove serious barriers to care. It allows families to better work with healthcare professionals to care for loved ones and helps fix the shortage of 100,000 psychiatric hospital beds that we need in this country. Our bill also advances telepsychiatry to help mentally ill patients in rural and underserved areas. I was proud to work and support this legislation as it was developed in our committee and eventually signed into law in 2016. And I know that your organization was a tremendous partner in this effort as well, and so I thank you for your tireless work. These landmark laws, whether it be cures or the Support for Patients and Communities Act, are examples of what's possible when we come together to solve the big problems that face our country. Improving mental health care and helping people escape the death grip of addiction are some of the most important issues we must address in Congress. And we have a lot more work to do, but I'm confident we can rise to the challenge by once again working together. So I thank you again for recognizing me with this award, and I look forward to continuing to work alongside you all on the issues facing behavioral health care providers in America.
I think after watching the three videos, you can see why we're so proud and pleased to be able to work with Senators Cardin and Portman and Congressman Walden. They are among the workhorses in the Congress, and having them as our champions is a real honor. And more importantly, their commitment to the behavioral health care advocacy in our industry, I think, is obvious in those videos. So now I'd like to invite up Jeff Hillis, the Chief Executive Officer of AdCare Hospital and a 2019 NABH Annual Meeting Program Committee member, to the stage so he can introduce our last speaker. Thank you, Jeff.
Good morning. As Sean said, I'm Jeff Hillis. I'm the CEO at AdCare Hospital in Worcester, Massachusetts. We're a member of the American Addiction Center family of companies. I'm pleased that our annual meeting will finish strong with our final speaker, Regina LaBelle, and I'm honored to introduce her. Regina LaBelle served as a political appointee in the White House National Drug Control Policy during the Obama administration, where she co-wrote and helped implement the administration's plan to address our nation's opioid crisis. Then, as Chief Policy Advisor to the Director, and later as Chief of Staff, Ms. LaBelle represented ONDCP before Congress, at national conferences, and with the media. Today, at her firm, LaBelle Strategies, Ms. LaBelle develops public affairs strategies for not-for-profit and public sector agencies that work to make societal changes. Ms. LaBelle is also a distinguished scholar and program director of the Addiction and Public Policy Initiative at the O'Neill Institute for National and Global Health Law at Georgetown Law. I'm glad she made the time to be with us today. Please join me in welcoming Regina LaBelle.
Good morning, and thanks for your flexibility. I cannot have the insights that someone from Speaker Pelosi's office would have, but I have 3 hours of remarks I can make in its place. No, I'm just kidding. We'll have plenty of opportunity for you to ask questions about the trajectory of the opioid epidemic. As was said, I currently am with the Georgetown University Law Center and advise nonprofits. In my position at Georgetown, I'm working on specific areas where we face barriers to evidence-based treatment for opioid use disorders. So what I want to do is start by speaking about first when I came to the Obama administration in 2009, what we were facing, the policies that we developed from 2009 until 2015, until I left in 2017. And then where the current administration has really picked up and has adopted many of the strategies that began then, and discuss what's left to do. So I use this not only because I am a mother of a son who spent many times putting together Legos, but it's also because how I felt when I started at ONDCP. All the pieces were there. The pieces of the puzzle to address the opioid epidemic, which we were facing at the time, were present, but we really had to pull them all together. What needed to be done was expanding healthcare access, building the treatment infrastructure, and developing the workforce. At the same time, our mission at ONDCP was to develop strategies to disrupt illegal drug trafficking, both domestically and internationally. We had a lot of work to be done. And this was a map from 2009 of the overdose deaths in the country. And you'll see that they are somewhat different than what we face today. But it's still, at that time, as today, was the #1 cause of accidental death in the United States, surpassing car crashes and firearms. It was 4 times the number of overdose deaths that we had in 1999. And in 2009, 3,000 involved heroin and 10,000 involved prescription drugs. At the same time, as we were seeing these overdose death rates, we saw an increasing rate of prescription sales around the country. So this is a heat map from 2000 to 2010 of the oxycodone sales per capita around the country. OxyContin, a long-acting form of oxycodone, was introduced to the market in 1996. The long-acting opioid was labeled as non-addictive and aggressively marketed directly to physicians. Also at the same time, there was a move to address pain more adequately, and pain was considered the 5th vital sign. From 1997 to 2002, OxyContin sales went from 680,000 to 2 million prescriptions. In Florida, of the top 50 dispensing practitioners in the United States, 49 were in Florida and in 9 counties in the state. So Congress had passed a law in 2008 called the Ryan-Haight Act. The Ryan-Haight Act cut down on the number of illegal online pharmacies around the country. So those illegal online pharmacies really needed a place to go. So they exploited loopholes in Florida state laws and some other laws, some other states, to begin illicit operations of pain clinics. Pain clinics in Florida were allowed to not only prescribe, but to dispense prescription drugs. So laws were passed to close those loopholes in 2010, 2011. And the number of pain clinics in the state of Florida fell. In 2010, there were 921 pain clinics. In 2014, there were 371. So if you were asked to serve in the Obama administration in 2009, you usually wanted to serve to save the economy, because that's what was before us, right? So I chose to serve working on drug issues, which were not front and center at the time, but were still obviously very important. But really, there was very little attention being paid in the national media to the #1 cause of accidental death, because they had a few other things on their mind: the US economy, economic stagnation, unemployment, and seeking to pass a stimulus package, as well as the Affordable Care Act. And all of you work in the treatment field, so understand stigma very well, but we still had many, the president asked our office to really take a look at drug policy in the country and how we could reform it. And we had a few issues before us, some of which remain today. One was addressing stigma. And this was a poll that was taken in 2010 that I don't think would be much different today, that fewer than 1 in 5 Americans want to closely associate with someone suffering from drug addiction as a friend, coworker, or a neighbor. We also had some built-in attitudes against naloxone at the time, the opioid overdose antidote, and as well as many positions, policies, and laws that oppose other harm reduction strategies, such as syringe services programs. So these were just some of the issues that we were faced with in terms of reforming drug policy in the country. So as a result, in 2011, the Centers for Disease Control and Prevention Director Tom Frieden declared the opioid overdose issue an epidemic. And he declared this in Atlanta at the CDC, and it was at the same time that we had a tour of some of the most devastated areas in the country, the Appalachian region. We were invited to do this. The Democratic administration was invited to do this and tour this region from Senator Mitch McConnell. And we worked very closely with Congressman Hal Rogers, a Republican from Eastern Kentucky, who was the chair of the Appropriations Committee at the time. But his district, he's always been in the forefront on substance use issues. His district has been one of the most affected in the country. So we did this tour of the region and as a result came up with a strategy, a plan to address the opioid epidemic. This was accompanied the National Drug Control Strategy, which the Office of National Drug Control Policy is required to issue annually. The plan had 4 elements. It called for educating patients, parents, and prescribers about the risks associated with long-term use of opioids, expanding prescription drug monitoring programs, increasing proper disposal of prescription opioids and prescription drugs, and enforcement efforts to decrease diversion of prescription drugs. So the first issue of education was quite important, obviously, because we had polling at the time that showed that parents, and this was an actual poll that was done by the Partnership for Drug-Free Kids, parents said that they would rather have their kids misuse a prescription drug than misuse a street drug, because at least they knew, they would know what the kid was getting at the time. So that was something that we knew we had to work on. So that was one of the pieces. The second part was patients, to make sure that patients understood the risks associated with using opioids, and prescribers to aid in understanding about proper opioid prescribing so that they receive more information than just from a drug sales rep who was marketing to them. Secondly, expanding prescription drug monitoring programs. At the time, there were fewer than half the states in the country, there were about 20, that had prescription drug monitoring programs, or PDMPs. And prescription drug monitoring programs at their best are intended to be an early warning system for a prescriber so that they can identify if an individual is showing signs of risky substance use. Third, increasing proper disposal. So we know then, and as is today, most people who misuse prescription opioids receive them from family and friends, and that person in turn gets them from one doctor. And that many people keep these prescription drugs in their kitchen cabinet, in their cabinets, just in case, for the future, right? So we knew, and there wasn't an easy way to dispose of them. So we worked with Congress to have legislation passed that allowed DEA to revise its regulations so that to allow for more convenient disposal of prescription opioids. And then lastly was law enforcement efforts. There were drug trafficking networks, obviously, that were diverting prescription opioids for sale, and law enforcement had to be a part of this plan as well. And then on the federal level also, there was the Affordable Care Act and Medicaid expansion, essential to one of our first strategies, which was to expand treatment availability and expand treatment access in the country. And the Affordable Care Act had as one of the essential benefits substance use treatment. So we put out this plan, but there was no new federal money that was dedicated to the opioid epidemic. Again, as I said, a few federal laws passed, including the law that directed the DEA to revise its laws to ease prescription drug disposal. States expanded PDMPs. Florida's prescription drug monitoring program was implemented in 2011. In addition, at the time, one of our main goals was to expand naloxone distribution. And we did it first through law enforcement for a couple of reasons. One is because in many of the most hard-hit areas at the time in rural America, law enforcement was going to be the first responder. They were going to be more likely to be on the scene. So we provided naloxone around the country. We encouraged law enforcement to have naloxone available to revive people from an overdose. Secondly, the reason why we sought to engage law enforcement was to start changing that dialogue between law enforcement and people with substance use disorders, so that it became reviving someone from an opioid overdose became part of community policing. And today there are over 2,000 law enforcement agencies in the country that carry naloxone. It's become a very common tool that law enforcement has used. In addition, another piece of policy that was very important to implement was the Good Samaritan Law. So the Good Samaritan Law basically if someone calls 911 because an individual was overdosing, they wouldn't be afraid that they would be arrested if they, by calling 911 and being in the presence, there might be drug residue. So that was another important piece of the puzzle. And then lastly, standing orders. Many states, so because naloxone is a prescription drug, many states and localities pass standing orders to allow for broader distribution of naloxone through pharmacies, through syringe services programs, and to third parties who might be at the site of an overdose. So all this happened. We were very busy, 2010, 2011, and 2013. And we had this little blip, right? USA Today had this great story. Painkiller deaths dropped for the first time since 1999. So we had about 5 minutes of yay, and we saw the deaths going down in a couple states, and opioid prescribing went down in many states, including in New York, Florida, and Tennessee. And we saw that fewer people were seeking out opioids from more than one prescriber. And we could tell that from the prescription drug monitoring programs. At the same time, in 2010, OxyContin was reformulated to make it more difficult to misuse, to crush or snort. And so that was an effort that was made. OxyContin was the first drug to receive an abuse deterrent, the first opioid to receive an abuse deterrent designation. So it resulted in about a 40% reduction in misuse of OxyContin between 2010 and 2014. So that was good, right? But reformulating OxyContin didn't make people with opioid use disorders disappear. What we had next was the second wave of the epidemic, which ushered in the heroin epidemic. Heroin-involved overdose deaths more than tripled between 2010 and 2014. And this is a CDC slide that you may have seen before that shows the 3 waves of the epidemic. I think it's a very nice visual of what we have seen. However, it assumes that once a new drug ushers in, the old drug is gone. And in this case, they've kind of piled onto one another. So as you can see here, what I said, that many people who were still had an opioid use disorder, it became much harder to get prescription opioids. The pill mills were closing. Prescription drug monitoring programs were coming in. Doctors were prescribing somewhat less. And so that's why people substituted another opioid. And in this case, it was heroin. We also could see some tracks of the drug traffickers also knew that this was occurring. So heroin availability went up around the country and costs went down. And it was more expensive and more difficult to get a prescription opioid than it was to get heroin. So people with pre-existing conditions, pre-existing opioid use disorders just switched. And again, we have with us, what remains with us constantly is our treatment gap of about 10% of people with a substance use disorder get treatment. It's better for opioid use disorders today. Today it's about 30%, but it's still not where it should be or where our goal is. So as we saw the phenomenon of heroin use going up, heroin overdose deaths going up, and we saw a different demographic of who was using heroin. They were younger, in more rural areas, so a wider demographic in many cases, and female. Women, they were still not the majority of heroin users, but more women were beginning to use heroin. Now, heroin is a drug that ordinarily is used at an older age, and we were starting to see a drop in the age of heroin initiation. So again, this is the second wave. This is what's going on in the policy space. And I'll tell you, one of the concerns I had at this point was, well, now it's not what people perceive of as an innocent person who just started using prescription opioids. We were very concerned that people would once again say, well, these are just drug addicts. We don't care about them, at the time this was happening. The other consequence of heroin use, obviously, is injection drug use. And in most parts of the country, people would use or repeatedly use the same needle when they were injecting. And so it caused these hepatitis C increases. And HIV in some parts of the country as well. And I'm sure you have heard of what happened in 2015 in Scott County, Indiana, a rural part of Indiana, a small community south of Indianapolis. Usually they had about 5 cases of HIV, but at its peak, the peak of the outbreak in Scott County, they had 210 cases of HIV. So Scott County, Indiana had very little treatment availability. It also did not have a syringe service program, and they were actually banned in the state of Indiana. So working with law enforcement and the then health director, Jerome Adams, who's now the Surgeon General, the state of Indiana declared an emergency, and they allowed for a syringe service program to be established in Scott County, which provided testing, access to treatment, and they referred people out to treatment, and the services that individuals would need, because the drug that was being misused, that was responsible for the outbreak was, at the time, was Opana. People were injecting up to 7 times a day. So the urgency of the situation was pretty obvious in the state of Indiana. This also, because of the increases in infectious bloodborne diseases due to injection drug use, the CDC did a study of other areas of the country that might be at risk for similar outbreaks. And they identified 220 counties nationwide, many of which are in Appalachia, many of which are in states that ban syringe services programs. And so that led to an actual recognition in many parts of the country that syringe services programs can be part of a solution. They don't just hand out needles. They can provide access to treatment. In many cases, they provide recovery supports and other types of health care that's needed for people who inject drugs. In the state of Kentucky, today, there are 50 syringe services programs because of their risk for outbreaks of HIV and Hep C. Another consequence of the opioid epidemic and injection drug use was the incidence of neonatal abstinence syndrome, or infants born exposed to opioids, around the country. This was a chart that shows the increase from 2004 to 2014. And we began hearing about this. The data that was collected wasn't great, but we were hearing reports from the state of Tennessee, from Florida, and in 2014, as a result of this, Tennessee did pass a law allowing for the incarceration of women who gave birth to infants with neonatal abstinence syndrome. But that was one of the only states in the country that had that type of law. And actually, our office worked very closely with Attorney General Bondi in Florida to make sure that the response to increases in neonatal abstinence syndrome in that state recognized the needs of both the infant and the mother, and the need for appropriate prenatal care, because if a woman feels that she is going to be at risk, she is more or less likely to get proper prenatal care. So this was an issue, yet another consequence of the opioid epidemic that we needed to address. That must be Nancy Pelosi calling. But again, so this is 2013, 2014. Aside from the Affordable Care Act and Medicaid expansion and existing funding from the Substance Abuse and Mental Health Services Administration that goes to states, there was little to no additional federal funding going to states to address this issue, to address increasing rates of opioid use disorder or the consequences such as HIV, Hep C, and neonatal abstinence syndrome, which in many cases led to increased rates of foster care and increased costs for a lot of counties and states. So now we enter the third phase and the current phase of the epidemic that we're in, which is fentanyl, increasing deaths and overdose deaths involving fentanyl. So this is a report from 2014 from the National Forensic Labs, which is a DEA testing lab that tests for drugs seized for the presence of certain drugs. And from this, from 2014, you can see where fentanyl was being seized was exactly where the overdose deaths involving fentanyl were beginning to be seen. Now, the good thing is that this lab exists. The bad thing is that it takes a while to test the drugs. So there's a lag time of 6 to 8, sometimes a year, between the testing for the presence of fentanyl and policymakers knowing that this is what's occurring. So we then started to see overdose deaths in Ohio, Massachusetts, 75, 80% and up involving fentanyl. And fentanyl usually was mixed with heroin. East of the Mississippi, white powder heroin, easier to mix with fentanyl. And the fentanyl precursor chemicals come from China. They either go into the United States directly by mail, by post, or they're coming in, they're mixed before, and they come in through ports of entry from Mexico. So again, just reiterating, when you can see this hockey puck that happened starting in 2015 of overdose deaths involving fentanyl. And it's tramadol and fentanyl, but for the most part, it involves fentanyl. So not only was there not additional funding, but there really wasn't a lot of national attention to the issue as we were seeing all these overdose deaths increasing. There was a lot of regional media, but really the national media had not paid much attention to the issue until about 2015. So as a result of that, there was an increasing call for action by the federal government. And in 2015, working with Congressman Rogers and Senator McConnell again, language was added to the appropriations bill that allowed for federal funds, and this really was as a result of the CDC study on at-risk counties. Language was added to the appropriations bill to allow federal money to be spent on syringe service programs. We got them to agree to allow for federal funds to be spent on syringe services programs with the exception of syringes. They said that we can only go so far. So that language is in every bill, but we felt at the time that it would send a really important message to parts of the country, as well as freeing up some federal funds for really hard-hit counties and cities, communities. In 2016, the CDC released its opioid prescriber guideline for chronic pain. And it basically was intended, again, we go back to the first plan, which was to seek to educate prescribers about opioids. Start low and go slow was kind of the meme of that prescriber guideline. It's a guideline, it's not a mandate. However, many states have adopted it as a guideline for their states and encourage opioid prescribers to follow it. In addition, there were two significant pieces of legislation passed in 2016. The first was the Comprehensive Addiction and Recovery Act, or CARA, and the second was the 21st Century Cures Act. So CARA it authorized some grant funding programs. It also had some policies that were intended to help increase access to evidence-based treatment for opioid use disorder. In 2016, the Comprehensive Addiction and Recovery Act, or CARA, it's a large statute. I'll go over a few of the highlights that were contained in it. The first, it allowed advanced practice nurses to prescribe buprenorphine temporarily. And that obviously depends on state law, but the purpose of that is to expand the number of people who can prescribe buprenorphine. And after taking a 24-hour course, they can prescribe, if allowed under state law. Second, it authorized an extensive number of new grant programs for naloxone distribution, for recovery and treatment. And those authorizations were both in the Bureau of Justice Assistance in the Department of Justice, as well as in the Substance Abuse and Mental Health Services Administration in HHS. Third, it increased VA oversight of opioid prescribing practices. There were some pretty severe cases of opioid overprescribing in some VA facilities that led to this. And then lastly, it also allowed for partial fills for opioid prescriptions if that's allowed under state law. So that's CARA. President signed that into law in 2016. There was the 21st Century Cures Act authorized $1 billion in federal funding, and that funding was intended to close the gap between those seeking treatment and able to receive it. President Obama called for $1 billion in funding in his FY17 budget, which went to the president which went to Congress in February of 2016. And so they didn't adopt a lame duck president's budget outright. So this is where the funding was sought. And it was a bipartisan effort for both CARA and 21st Century Cures Act. After these authorizing statutes were passed, the really hard part comes in of getting the money into the budget. And so the FY17 budget included $1.1 billion in funding for both 21st Century Cures, for the treatment funding, and for CARA. So the 21st Century Cures funding was to go in 2 years, 2017 and 2018. But at the time, it was the greatest amount of money ever dedicated to the opioid epidemic, or frankly, ever dedicated to addiction treatment generally outside of SAMHSA's grant program. So in 2017, HHS issued, as it says here, over $800 million in grants to the states, $500 million under the 21st Century Cures Act, and the rest in various opioid-directed funding grants. The 21st Century Cures Act money was called the STR grants by SAMHSA. It required that 80% of that funding had to go for treatment. And that money went to the states in April. It was a pretty fast turnaround for states. I mean, states that had basically had starved treatment systems for years had to come up with a plan for how they were going to spend this money. And there was a Politico article about 7 months after this that said that many states hadn't spent the money yet. And the reason why states haven't spent the money is, number one, because it was one-time funding, so you can't build a system on one-time funding. And secondly, because states didn't necessarily have the infrastructure, they certainly didn't have the workforce that was necessary to develop a system that could spend these monies. So I compare it to a glass. If you continuously fill a glass with water, that glass doesn't get bigger, it just spills the water everywhere. So there have been, and there'll be continuous studies of how the states are spending the funding. But that is one issue that remains. The CARA program was also funded in 2017 at about $188 million for various grant programs through Bureau of Justice Assistance and SAMHSA. Some of those grants, they don't all go through the states. Some of the CARA grants go directly to cities or counties to address various aspects of the opioid epidemic. So this brings us to 2018, last year. In 2018, additional funds went to states. So the second tranche of money for STR went out, $500 million. Excuse me. And also, the state opioid response grants went out, and that was about $1 billion. The SOR grants, again, they're administered by SAMHSA, and the grants are intended to build upon the STR program. Now, STR, 80% of that funding is supposed to go for treatment. SOR says that the full continuum has to be funded, so prevention, recovery, and treatment. And SOR also requires that any treatment program receiving funding through this has to make available medication-assisted treatment. So that was a very significant message that was being sent to states and was really unprecedented, and that happened last year. In addition, as Congressman Walden and Senator Portman said, the President also signed the Support Act, H.R. 6, last year. I'm going to give you highlights. It's 600 pages long, but I'll give you some of the highlights from it. It permanently authorizes advanced practice nurses to prescribe buprenorphine, so it extends the length of time that advanced practice nurses can prescribe, and that was included in the previous act, in CARA. It also, as Senator Portman said, states can apply under a plan amendment to lift the IMD exclusion. That's for a 5-year period that states can apply for this plan amendment. Beginning in 2020, it also allows for Medicare coverage of methadone. In addition, the Ryan-Haight Act, which was passed previously to cut down illegal pharmacies or rogue online pharmacies, had some provisions in it that made telemedicine and telehealth more difficult. So this also included provisions to address that issue. It reauthorized the Office of National Drug Control Policy, and it beefed up the authority of that office, or at least reasserted the authority of that office, excuse me, to be a convener and a coordinator of drug policy, which is the intended purpose of ONDCP. In addition, it authorized a loan repayment program for the addiction treatment workforce. Now, it authorized that. It did not appropriate it in the budget, not all of the funding. So there are many advocates on the Hill who are seeking to now get that funding passed and included in the FY19 budget in an effort to build up the treatment workforce around the country. In addition, the other really important piece is that I failed to mention is that the President in 2017 established a commission headed up by Governor Christie, a bipartisan commission that issued a report that had about 56 recommendations, some of which have been implemented, but the importance of that report was that it reaffirmed the administration's commitment to addressing the epidemic. And then also, they had a public health emergency declared in 2017 that, again, kind of focused the mind and focused the energy of agencies on addressing the epidemic. Excuse me. So this has been a very bipartisan issue all along. And we hope that as we enter the next 2 years, that it remains a bipartisan issue and that it doesn't get bogged down into partisan bickering. So a few states have seen decreases in overdose deaths: Rhode Island, Massachusetts, Idaho, Wyoming, North Dakota. But it's really way too soon to say this is a trend. It's way too soon to declare victory on this issue. And anyone who thinks that we can kind of spike the ball should look back at that 2014 USA Today headline where it was touted that painkiller overdose deaths had come down. So some parts of the country, like Idaho and Wyoming, have seen overdose deaths decrease. Primarily, they're not seeing the fentanyl that Massachusetts, Rhode Island, Ohio, the District of Columbia are seeing. And actually, I bring up District of Columbia because that's a really important lesson in what can happen, what's happened in this fentanyl epidemic. So the District of Columbia never really had a big problem with prescription overdose deaths. But they have had a long history, DC's had a long history of a cohort of people who are longtime heroin users. And a couple years ago, they started seeing, the medical examiner in DC started seeing these heroin users dying in greater numbers. And it was due to fentanyl, and fentanyl that got into, in the District of Columbia. Now, the District of Columbia is now the 4th highest rate of overdose deaths in the country. And that was unprecedented from before. They were not even near the top 10. The average person who's dying of an overdose in the District of Columbia is a 50-year-old African-American male. And so they're frankly just now starting to address the issue and looking at having the police department carry naloxone and doing some of the things that other states have been doing for quite some time. So other states have put forward some novel approaches to the epidemic, and I say novel only because they're new, not because they're not. I mean, they're very, they make total common sense, because we know from the data that the people who are more likely to overdose and at risk are people who have been newly released from prison and women after giving birth. But a lot of our policies didn't really address those two populations. So Rhode Island introduced a medication-assisted treatment program in 2016 for their prison population and their jail system. Now, the beautiful thing about Rhode Island is it's a really tiny state, and their prison and jail system are unified. So they could implement this in a pretty easy way. There's only a couple people to talk to about implementing it. Implemented in the prison and jails, but really importantly, connected people to treatment upon release when they were re-entering the community. So this resulted in, and this is a JAMA article, this resulted in a 61% drop in overdose deaths in that re-entry population, and a 12% overall drop for the state of Rhode Island. So other states are now starting to follow this. Vermont is now implementing medication-assisted treatment, screening, MAT, and connecting to treatment upon reentry in their prison system. And several other states are looking at this right now. New York is looking at it, although Rikers has had a similar program for a long time. The District of Columbia is looking to expand it. Maryland has legislation pending. So several, and California is also looking to expand this. It's before the legislature in a lot of states. I was looking at Maryland's, the fiscal note attached. It'd be $20 million that they say it would cost to implement the program. Now, $20 million is what the state of Maryland got over a 2-year period from the federal government. So that just shows the need. I'm not sure, I think that number might be somewhat inflated, but regardless, that's what the members of the General Assembly have to decide whether or not they're going to invest this type of money in this population. The other policy that states are looking to emulate and expand is Vermont's hub and spoke program, which allows for, especially in rural areas, it's a good way to allow for people in more rural areas to have access to treatment. The nation has emphasized decreasing rates of overprescribing, and rates have come down, although in 2017 they were still 3 times what they were in 1999. And federal investments have been made in unprecedented sums. But there is still, again, there's still a lot more that we can do. So this is the kind of the continuum of care that is traditionally looked at: prevention, treatment, recovery. And also, I think looking at reducing harms to reduce some of the consequences of the opioid epidemic and substance use disorders generally is important. increasing intervention points, and then how do we approach this from a law enforcement standpoint? Because fentanyl is still, the chemicals that are coming in are illicit. It's not illicitly manufactured fentanyl that is getting into the drug supply. So from prevention, certainly there are primary prevention issues we need to look at, as well as the social determinants of health that is driving rates of substance use disorder around the country. Reducing supply and illicit fentanyl remains an issue, as I said. The Chinese chemical industry is vast and unregulated, and when we were in the Obama administration, China agreed to ban certain fentanyl analogs, and the Trump administration also said last year that they got China to ban a vast array of fentanyl analogs. Now the challenge is that these are chemicals, synthetic drugs. They can be changed quickly, and if you ban one analog, that doesn't mean that tomorrow they won't develop a new type of analog. And synthetic drugs really pose a very big problem for our efforts at law enforcement, at disrupting drug supply. And so fentanyl, I think that fentanyl is just the beginning of what we're going to see in the future. Because you won't need people, you just need chemists, right? You need a lot less overhead. You don't need crops. You don't need to do the whole drug trafficking that we've seen in the past. And then treatment, obviously, is still an area where we need a lot more work, a lot more workforce capacity built. And I go back again, Washington State estimates the majority of people in their state with opioid use disorder exit a prison or jail each year. And they're up to 120 times more likely to die of a drug overdose after release. So that remains an area. The Bureau of Prisons in the federal government has to come up with a plan as a result of the First Step Act to look at how they are going to address treatment behind the walls. And then once they do the plan, they're supposed to implement it. The plan is supposed to be due this month, and we'll see what occurs then. The second piece in treatment, obviously, is Medicaid barriers to medication-assisted treatment. Pre-authorizations, low rates of reimbursement still exist. Now, the SUPPORT Act sought to address some of those issues. We'll see how that manifests itself. Because the Medicaid population, there's 4 in 10 adults with an opioid use disorder are covered by Medicaid in this country. And at the same time, about 53% of counties don't have a data wave physician who can prescribe buprenorphine. And the last piece of the continuum that Congress is still looking to address, there are some grant programs that will beef up recovery supports. There are some states where recovery support programs are being covered by insurance, which is good and hopefully a wave of the future. So I think the main issue I think the theme of all of our policy efforts have been that we need to make sure that we are treating addiction from a policy standpoint, as an acute rather than a chronic. That's what we do, is we treat it as an acute rather than a chronic issue. And these one-time grants are good. The $1.5 billion is more than we've seen in ever. But again, that assumes the problem's going to go away in a couple years. And I know from talking to these states that, and I know from my own, I served as the legal counsel to the mayor of Seattle. There were many times we would not take federal grants because we knew they'd be gone in 2 years and we couldn't fill in behind them. So if a state is getting $20 million to address the epidemic today, and they know they're going to continue to have alcohol use disorders, meth might be following, they're still going to have opioid issues, they are not going to be able to build long-term sustainable programs without a long-term sustainable source of funding. And so that's really what's before us. And I don't see, I know that there's some thought given on the Hill to having some long-term funding, but there's really not much traction's been gained. And the advocacy groups that are working on that, I think, are just trying to keep up with every day, trying to get these smaller appropriations funding that was authorized a couple years ago. And at the same time, so some people have come up with some estimates of, and I'm asked all the time, so how much money do you think we need? I'm not going to say, because I think I'd come up with the wrong number. But I do know that a 2013 estimate of economic costs of the opioid epidemic estimated at $78.5 billion. So 1.5 billion sounds like a lot. It sounded like a lot to me when it was appropriated. But really, in the general scheme of things, it's not a lot when you look at states and look at counties and the fact that they can't afford to do some of the most basic treatment, basic recovery supports, basic prevention work that they need to do. And at least one article in JAMA from a couple weeks ago estimates we won't reach the peak of the epidemic until about 2022. So we need the public and private sectors to come together on this issue. Obviously, I think a lot of that has been done. There's always more that can be done. The federal government needs to fund the continuum of care on an ongoing basis and make sure they recognize this is a chronic issue, and build incentives and alliances with the private sector to expand treatment access and make sure insurance companies comply with parity laws. So I want to thank you for your time this morning. As I said when we began, we have all the pieces in place. All the pieces, we just need to put them together to really make sure that we're addressing the opioid epidemic from a long-term sustainable program, so that in 10 years, when hopefully we can look behind us, we have built a system in this country that can prevent, treat, and help people enter recovery regardless of the substance that they use. Thank you. And I'm happy to take any questions that folks might have.
I was going to say.
Oh, I'm sorry.
We have time for a few questions.
My name is Greg Murata. I have a question related to how do we apply either lessons or opportunities from history, because we've gone through cycles in this country with phases of addiction. You talk about long-term sustainability, treatment, recovery, et cetera. How do we avoid making the same mistakes that have been made in the past?
Well, so if I weren't an optimist, I wouldn't be in politics. I would have given up a long time ago, and I wouldn't have worked for the number of political figures that I've worked for. So I really believe, I feel really good about the future of how we're going to treat addiction in this country, because I can already see that it's changed. When you have, the people, when you talk to a law enforcement officer who is excited about the fact that they're helping people overcome their addiction, as opposed to looking at it as a moral failing. Again, the polling numbers, stand for themselves. We still have work to do, but I really believe that the opioid epidemic, as awful as it is an on-ramp to the broader conversation about substance use disorders in this country. And at the Office of National Drug Control Policy, the second person we had working there as the director was in recovery himself. And there was a 60 Minutes piece that he appeared in, and he, I think, was able, I can't tell you the number of people that came up to him after and said how important it was for them, that message that he was in recovery, the message that sent, that because in the past, we had some very good directors, but they came from law enforcement. There was a general, and they had kind of a more black and white approach to the issue, and so I think there's a bright future for this, but it really takes recognizing that there's a recovery movement and a one-on-one. As Michael would say all the time, you can't hate up close, but you don't buy that.
No, I appreciate the response. You opened the door for a follow-up, though. When you talk about addiction itself, isn't that the product of mental and behavioral health challenges in the country? So how do we bring those two together? Because in my mind, and in the reading that I've done from a historical standpoint, that has always been the area that has been overlooked.
So co-occurring disorders? Yeah, I mean, I think it's really interesting that I think that sometimes in the advocacy world we think that we see things from that if they get it, they're going to take it from me. And I think, unfortunately, sometimes we have that in mental health and substance use, that, you know, people with co-occurring disorders are served by both parts. And we don't necessarily do that. I think Patrick Kennedy has been very outspoken on both sides of the issue, but he's probably one of the few that speaks to the issue from both perspectives. And I do think that there's more work that can be done in a partnership, and that partnership hasn't really developed yet.
Full disclosure, he's one of my board members, so I've heard that story.
Yeah, I'm sure. Yeah, great.
Thank you very much for your presentation. I had a question about two of the slides and sort of how they interact. You put the slide up about the progress that was being made between 2010 and 2013, essentially making prescription opioids harder to get, and then a decline. And then following that said, those patients likely transferred to using heroin or ultimately fentanyl. But that line on the next slide sort of showed the level of prescription opioids staying about the same or maybe going up a little bit more. If those patients are switching, why are we not seeing a better decline in the prescription opioid overdoses?
Yeah, because of the availability of heroin also had people who might, I mean, that's a great question. Because people there were many people using alcohol, marijuana, which was traditionally first, and then going directly to heroin, as opposed to getting prescription opioids in the interim. So it wasn't a one-for-one replacement, obviously, but we were seeing an increase in availability of heroin and an increase in heroin use as well at the same time.
Thank you.
Regina, what do you think? You talked about the issue of the sustainability, these grants, something our organization is very interested in and been trying to develop strategies to change that discussion. You outlined it exceptionally well, and we agree with what you were just saying. How would you suggest, you said there hasn't been traction on that. How would you suggest all of us think about that so that we can maybe change that discussion?
Well, I think the governors can play a really important role in this, because you think about, I mean, I always go back to New Hampshire when I think about this. So the state of New Hampshire has a funding source. Anyone here from New Hampshire? If I mess it up, tell me. But the state of New Hampshire has a funding source that from their alcohol tax that goes to pay for substance use. The state legislature has kind of diverted those funds for a number of years, but now they're fully funded because they have a private sector entity that gave them some funding. However, if they don't get the $23 million from the federal government, I don't know how they're going to sustain any of their programs. They have a really low unemployment rate. The governor's doing really interesting things in terms of a recovery-ready workforce. So I think if you have a bipartisan group of governors who say, this is what's going to happen to me with these one-time funds you keep giving me, I do think that there's kind of holding out hope for the big opioid settlement. I think that's what some cities, counties, states are thinking they'll be able to fund this on. But you know, maybe that'll happen. That would be great if it did. I don't think that we should have to sue to get people the treatment funding that they need. You know, that's a fundamental purpose of government, is to get health care to people. So I think the governors and state legislators have to go to Congress and say, this $1.5 million is good, but it's not good enough.
And then the other part of that is, you talked about public-private, and that the infrastructure doesn't exist, or it's insufficient on the public side. How would you, what would you tell all of us about how to change that discussion? Because we have a lot of the private sector providers here, nonprofit and for-profit, but it's very idiosyncratic in the states about how that happens, and it seems like maybe there needs to be a sort of a federal move to at least encourage and talk about why that can be more effective, because it's a historical thing about the public sector and all that.
Right. I mean, so I have this dream that we had this map at the CDC, like they did with Zika, of a heat map of where the treatment deserts are. So where are the overdose deaths, where are the treatment deserts, and how do we get the workforce, so we have an addiction and recovery core that goes into those areas of highest need. And that's where, if you have an FQHC there, if you have a federally qualified health center, make sure they have treatment provisions. But if we map it out, and that's why I think my old office is so important to this conversation, because they're the only ones that can talk to both healthcare and law enforcement at the same time. And so it's, you know, if we looked really closely at where the treatment deserts are, what are the public sector resources, what are the private sector resources, then we can make investments in those areas. But that goes back to the lack of sustainable funding, because again, if you're funding a person on a grant that's going to go away in a year, you're not going to want to do that to that person. So, thanks.
Hi, I'm Denny Carice. Thank you very much for your talk. There's a couple of things, but to build on that, I wonder sometimes why they don't make this a distressed industry the way they did with farming in the past, making it, you know, a number of revenue sources and funding available. Mm-hmm. So that seemed to me like it would be a decent way to go. One of the things, it's interesting to me that to prescribe buprenorphine, and I'm glad they've changed it to allow higher level nurses to prescribe and whatnot, but so you have to take an 8-hour course and to learn about this. Then you have to get a waiver and you're available to prescribe to 25 people, and then you can up it to 100. I'm just curious if anybody's thought about an additional 8-hour course and a waiver and a limit on prescribing opioids.
Yeah, so Senator Gillibrand sent out, introduced legislation yesterday, and I can't remember the Republican that's on it, but that called for a 7-day limit on opioid prescribing, and I saw her tweet. She had 10,000 responses opposed to that.
I know.
Because the pain community is very concerned, as they should be, about access to opioids. So that's probably why. Yeah. I'm not sure. I don't think this legislation didn't go anywhere. It was pretty startling to see the response that she got.
Yeah, it is interesting. It's the confluence, the comparison of the two is, you know, I think the answer is in going the other way, but it's interesting to me that there's all these, you know, guidelines and restrictions around one prescription. Just another thing, a concept. So I think that as a scientist and a clinician, I am backing anything that's evidence-based. MAT, you know, cognitive behavioral, open, you know, provide all of it. What I'm worried about is that the country is really pushing MAT for good reason, though, but to an extent where we're creating a system where states can say we're treating more people and insurers can say we're treating more people by delivering MAT, and sometimes to the exclusion of therapies, right at the time when I think we're on the cusp of an epidemic of a drug abuse issue with cocaine and amphetamine, for which there's no MAT and no MAT in the pipeline. So I worry at some level that we're creating a larger system that is really focused on that delivery of care at a time when there's not going to be the availability of that care for the next thing coming down the pipeline with I think it's 97% of what's confiscated at the border right now is cocaine and amphetamine. Now, the opioids make it in through the mail, of course, so it's kind of an unusual comparison. But, you know, again, I'm all for MAT. I wish we had MAT for all the drugs of abuse. But when you create that system, you create a way for insurers and whatnot to serve more people in a more cost-effective, less expensive way, at a time when we're going to need to go back at some level to providing more, you know, cognitive behavioral and other therapies that take longer, cost more, and that's a concern.
Yeah, absolutely. And that's where the short attention span of the grants come in. The strategic opioid response grant really should be a strategic addiction response grant, and it should last longer. But but on a positive side, we have their attention. Now we need to take it to the next issue. All right. Thank you very much.
Regina, thank you so much. That was the best presentation I've ever seen on this topic, and I've seen many. And thank you so much for your leadership on this issue. I'm now going to ask Mark to come up with some closing remarks to our meeting.
Well, I just want to thank everyone again for coming to the meeting. I think heard very positive things, and I hope you learned a lot. I know a lot of people were networking and learning from each other. So again, we very much appreciate everything that you do every day. We are going to, as you have heard throughout the meeting, the association have a very aggressive agenda. We need all of you to be part of that, as you heard yesterday, so we will continue to be reaching out and working with all of you. So again, thank you all for coming, and have a safe trip home.